Okay, so let's start. Thank you very much, everyone, for joining me today. My name is Dr. Mahin Ashraf. I am from Bangladesh, and hopefully you know me by Imaging Study YouTube channel. So today we are going to talk about 10 ultrasound cases, and hopefully these cases will be interesting and will be beneficial for the beginners and will be interesting for the experts. So without any further ado, let's jump into the main topic. So before starting, if you are new to our this program, so we have a YouTube channel named Imaging Study, which has already got 59K plus subscribers. And fortunately, many of you have joined here with me today. We upload irregularly, actually, not regularly, but we try to upload some cases in our YouTube channel. So if you haven't been there, please try to make a visit, and hopefully among these 464 videos, some will be beneficial for you. So let's jump into the topic. So we have got many people connected to our live session. I can see here. And hopefully we are from many parts and many different parts of the world. Fortunately, our previous sessions were uploaded in our YouTube channel, and we have found many interested persons to view or review them. So thank you for being with us for a long time, and hopefully you will enjoy rest of your time with us for a few minutes. So let's start with the case number 1. So here we are going to show you a case which is actually a 40-year-old female patient who came with a lower abdominal pain and hypertension. So it took our attention that the patient was not very bulky, but she already got a hypertension for a long time, not for 1 or 2 years. She just gave us the history that she had a long history of hypertension at the age of 40. So let's see what we have got on ultrasound. So when we jumped into the hepatic ultrasound, you can see their diffuse cystic appearance of the hepatic parenchyma. You can see the gallbladder here. It was very difficult first time to see the liver and find the gallbladder among these whole cystic lesions. So we freeze the image. You can see this one is the gallbladder. It is pear-shaped structure. But these round anechoic structures are nothing but the hepatic cysts. So these are multiple hepatic cysts throughout the hepatic parenchyma, which suggests it to be a polycystic liver disease, I think. There is a differential of Caroli disease, which has slightly different features. So we don't want to go for that. But if you are looking at the liver with this type of cystic lesions, you definitely should look for the kidney also. So we jumped into the kidneys and we found all the cystic structures of similar appearance present within the kidney. You can see a glimpse of right kidney here. I didn't took the picture of the kidney during the scanning, so I can show you the still pictures. So just freezing the image, you can see a glimpse of kidney, but this is not a good one. So we freeze the image and you can see multiple cystic lesions throughout the hepatic parenchyma, indicating the polycystic liver. So here we found some cystic lesions here also. And I think I have missed the, we have some renal cystic structures. Here you can see some tiny cystic structures within the kidney, but the kidney is not still enlarged, fortunately. And there was no hematuria on urine RMA, which is also very common in polycystic kidney disease. So the features are quite earlier for the kidneys right now. Now we can see the cystic lesions here also, and you can also see the kidney on the right side. Now, when we jumped into the left kidney, we also found some cystic lesions here in the kidneys, in the left kidney. And these are not very prominent feature, rather the liver is more involved here. But you know, we can just see or demonstrate these cystic lesions with 3D ultrasound. So I'm not here to show you the hepatic cyst actually. So definitely I have a plan to show you. So here you can see we just put some 3D over the liver, as the liver has multiple vacuole-like areas, so they will easily be shown on the 3D. So now you can see these cystic areas here within the liver. Okay, let's see another picture. You can see these cystic lesions within the liver. So I didn't need any manipulation or too much reconstruction. I just took the 3D prop, put it over the abdomen, took the image of the liver, just clicked on the 3D or 4D option. Then the image came almost like this. So I just rotated a little bit. So it's quite easy. So here's another picture, and you can see the cystic lesions. There's a glimpse of a right kidney, which was not my target for this case. Now, you can understand that I'm not showing you this case only for the liver cyst. Okay, so this is a female patient. So let's jump into the uterus of this patient. So I'm actually showing you this picture, this case for the uterus, not for the liver. So let's jump into the uterus. Patient has got the history of chronic lower abdominal pain. So she came with also that history. So now you can see this is the uterus. Okay, so it's slightly bulky, I think, but not too much. And if you look at the inner side, you can see there is a hazy collection within the uterine cavity. Okay, now what about the endometrium? When we are seeing the hazy collection within the endometrial cavity, we definitely should look for the endometrial thickness. Now, if I freeze the image a little and just move a little bit, now which one is the endometrium? So let me annotate a little. So you see this hypoechoic line over here. So this is the demarcating point between the myometrium and endometrium. Here you again can see this demarcating line. So this is the posterior part of the endometrium. This is the anterior part of the endometrium. So definitely the endometrial thickness is increased. We'll measure it a little bit later, but it is increased by visualization. So this is the thickened endometrium. Now, if I tell you that the endometrial echogenicity is not much echogenic, you see, when you get the secretory phase endometrium, those endometrium are echogenic, but this one is not echogenic. Rather, you can see it is quite heterogeneous, and you can see hypoechoic areas within. So it indicates that this endometrium is having inflammatory change. So this is a thickened, heterogeneously hypoechoic endometrium with hypoechoic collection within the cavity. So it should be a case of endometritis. So this patient is a case of endometritis, and that's why I'm showing you this case, not for the liver cyst. So this is the transverse section, and you can see this is the collection in a magnified image. Always try to magnify the image. It will give you a good view and detail of the picture of the structure. So hazy collection within the endometrial cavity. We put the color Doppler. This is a non-pregnant uterus. So on power Doppler, you shouldn't see so many vascular flow towards the endometrium. No need of flow for a poor endometrium like this. But you are seeing that it's a lot of vascularity going on here. So it's definitely due to the inflammatory process. So this is definitely a case of endometritis. So here's the picture. The uterus doesn't look bulky on the measurement. In our case, we go for the anteroposterior diameter of the body of more than 4.5 centimeter to say it bulky in a reproductive aged woman. So it varies from center to center, we know, but we follow that measurement. So on the right side, you can see the endometrial collection measures around 11 millimeter. If it is more than 3 millimeter, we think there is something abnormality going on, and it is 11 millimeter, which is quite high. And we can see that there is a thickening of the endometrium. We measured it separately because there is endometrial collection, and you can just sum it. So this is 0.8, 0.8. So plus, it should be 16 millimeter endometrium. Okay, so this is the color Doppler picture, and you can see there is a good amount of vascularity within the endometrium. So you can just generate a 3D image here. So you put the 3D transducer and you can get this type of image. So now you can see this is the endometrial collection, which looks quite hazy. So this is a chronic case. Unfortunately, this is not an acute case. Patient has no history of acute pain or fever. Patient is not feverish, so she had the chronic pain. So in this type of situation, we think of two important things. The first one, for our country, tuberculosis is quite common case. So we think about the tuberculosis. So we need to check the swab, and we need to check the swab from this part, this collection, and then from swab test, we would love to go for the tuberculosis exclusion. Another one, uh, you know, this is an endometrium with chronic features, like a patient is giving chronic feature, but you can see good amount of vascularity. So you definitely should exclude the malignancy, because underlying malignancy for the endometrium should always be excluded, because at that part we actually think about the patient's morbidity or mortality more. Okay, so this is another 3D image. So we took the tomographic ultrasound imaging. Look at the picture. We just took the transverse section, put the 3D, and we got the image. So we opened the um, multiplanar scanning, or the tomographic ultrasound imaging, TUI, in our machine. So you just choose the area you want to see on the sagittal section from the axial cut. Then all the slices came here. So we just chose another section from sagittal. We took the slice, and we can see now some coronal sections here. Not very good, but it's usable. So here we took the sagittal section and choose the area we want to see, and the axial cut. So these are the axial sections. Our main principle was to exclude any visible mass within the endometrial inner margin, but there was no definite mass. So we were focusing on tuberculosis more in this case. So this was a case of polycystic liver and kidneys along with endometritis. Now just jump into the case number 2. So we have many participants here. Thank you for joining. Fortunately, it's more than last week. Okay, so now come to the case number 2. So this is a 6-year-old male patient, okay? So there is a history of recurrent upper and central abdominal pain, which is common for this age kids. So let's see what we have got on ultrasound. So here we have put the ultrasound over the liver, and you can see the liver looks quite good. This is the gallbladder. Everything looks quite okay. This is the inferior vena cava from, this is the left lobe of the liver. This is the right lobe. Okay, everything looks normal except for the porta hepatis. If you look at the porta hepatis, you can see there are multiple tortuous vessels over here, but you can't see the portal vein. So that took our attention. Where is the portal vein? So let's jump into the color Doppler picture then. So we put the color Doppler. You can see the hepatic veins. Okay, these are all okay, but not the porta hepatis. We can't see the portal vein. Rather, you can see there are multiple tortuous vessels showing different colors, red and blue. That means they have different directions also. Now, it apparently looks like some cavernous transformation or portosystemic collaterals-like appearance. So it took our attention. We want to solve it. So again, we want to see it from different angle, and you can see that then there is no portal vein here. If there was a portal vein, you should see that it is coming like this. So there is no portal vein. So this is the absence of portal vein. So liver is getting supply from different collaterals. So what it can be. So let's see here. So this is the peripancreatic region. It is also showing some different vasculature here, like a collateral. And you can see this is the porta hepatis region, which is also showing some tortuous vessels. So here's the tortuous vessels on grayscale, and this is the color Doppler picture. Now we want to check the pulse wave Doppler from this area. So we took the sample, and you can see all showing portal vein-like or venous-like flow from different directions. Like you can see similar type of flow towards the liver, from the liver, so different directions. So there is a flow from different channels trying to supply the liver in absence of portal vein. We call this feature as Abernethy malformation. So in case of Abernethy malformation, you won't see the portal vein and the so what will be the splenic vein and supramesenteric vein? They will try to find their own way to drain. So they may drain into the inferior vena cava or elsewhere. So we jumped into the umbilical region or paraumbilical region. So on the paraumbilical region, at the lower part of the or you may say at the proximal inferior vena cava and the umbilicus, when we put the ultrasound probe here, we can see there's the intestinal loops. We have nothing to bother here, but you can see multiple dilated venous blood vessels or venous channels here. So these are very tortuous, large vessels. We don't usually see this type of vessels at this level actually. So we would color Doppler. Now on color Doppler, you can see very high flow here. So these are showing aliasing, which is very unusual because at this level, even inferior vena cava doesn't show this type of aliasing. So there are multiple prominent tortuous vessels showing high flow. These are all venous channels. We took the pulse wave Doppler. Unfortunately, I think, I have that picture. So we took the sample. These are not arteries. These are venous flow. So we can see some tortuous veins around the inferior vena cava, which also drain into the inferior vena cava in this case. So we also check the urinary bladder of this patient with high frequency, and you can see echogenic debris within the urinary bladder, which may be due to previous or any recent inflammatory process or even hemorrhage. We don't know. So we'll call it a urinary bladder debris. The wall is quite not thickened. So don't misunderstand it as an acute inflammatory condition of the urinary bladder always, because this debris may be a result of urinary renal infection, or maybe the renal hemorrhagic appearance or anything else. So just try to note it as a urinary bladder debris. My clinician is far expert to diagnose further. Okay, so these are urinary bladder thick debris. Okay, so this is actually a case of Abernethy malformation where you won't see the portal vein, and this is a very rare anomaly, and the actual supply will be supplied by the portosystemic collaterals. Okay, so it has many different types. I don't want to go further here. But you need to search for the superior mesenteric and splenic vein drainage. So the best thing to do is the hepatic angiogram, I think. So if you go for a CT angiogram, then you may easily understand the drainage pathway, actually. So let's jump into the case number 3. Okay, so I have what I don't know how to off the this something. Let me just check. So there is a caption generation going on, but my English is not good to show the actual thing that I'm talking. So you can just click on the 3-dot button, and then you can just close the caption. It's automated caption, so it's not accurate actually. Yeah, you can do the phenogram also. Yeah, definitely. So if you go for the hepatic angiogram or hepatic angiogram, then you can also see the arterial flow also. Okay, so liver is getting supply from the portal phase also. So if you can get the 3-phase view, then definitely the picture will be better, I think. Okay, so anyway, let's jump into the case number 3. So this is a 30-year-old female patient. Okay, so she came with a painless swelling at the middle aspect of the right arm. So let's see what we have got on ultrasound. So here you can see it is the middle aspect of the right arm. So here you can see there is a solid lesion. This is an oval shaped solid lesion just below the subcutaneous layer, within the muscle layer actually. So it's oval, and it is not homogeneous, it is heterogeneous, because this cystic area at the central part, I think it's not due to the necrosis only. Patient had gone through FNSC or biopsy, I'm not sure, just a few days ago. So it might be due to that reason. Okay, anyway, so this is a heterogeneously hypoechoic oval lesion. This is a well-capsulated well lesion. But if you look carefully, just let me freeze the structure at a point. I think that will be beneficial. Okay. You need to search for the exact moment, actually. Yeah, we can freeze it here. So you can see at the, not at this part, it's not well understandable, but at this part, you can see there is a tapering end here. So whenever you see there is a hypoechoic oval lesion with a tapering end, which is located along the way of any important nerve, you should first think about the nerve sheath tumor, which is more common in our practice. So this is actually a nerve sheath tumor, which is located along the line of the median nerve here. So this is located along the median nerve. So this is possibly attached to the median nerve here. So this is the nerve sheath tumor. So let's put some measurement, and you can see it's around 2.5 centimeter long and 1.7 centimeter in anterior posterior diameter or height. Okay, so we have put some color Doppler, and you can see on color Doppler both peripheral and central flow, but predominantly the peripheral flow is seen. So we just need to adjust a little bit, because we need to assess the vascular structures around this lesion. So this is the brachial artery pumping here, which is located quite nearby, but not attached to the lesion. So you need to mention it, because the brachial artery adjacent to this lesion should be carefully checked during the surgical procedure, number one. Number two, this is the common site for median nerve. So that's why brachial artery is guiding us that this is originated possibly from the median nerve. Okay, so this is a nerve sheath tumor, hypoechoic oval lesion, which is having some heterogeneous texture inside. So we took the sample. I always say that if you see a lesion, you put color Doppler, you see the vascularity of the lesion, and you always check the pulse wave Doppler from that lesion. So you can understand that how a flow of a tumor of different type looks like. What is the flow pattern of a fibroid? What is the flow pattern of a nerve sheath tumor? You need to realize that practicing. Okay, so it's showing a moderate resistant flow of 0.56 of resistive index. Okay, so not very high amount of flow. It's like a 9 centimeter per second, which is common for the nerve sheath tumor. So this is a peripheral nerve sheath tumor of median nerve at the middle aspect of the distal right arm. It was right arm or left arm? Okay. So let's jump into the case number 4. This is an interesting case. If you're from Bangladesh, you know that we had some situation on last August. So this was a patient from that era. So it's a 33-year-old male patient who had a history of gunshot injury. So let's see, you can see this is the pellets of a shotgun. So he got this type of injury. So when he came, there was many part of the body showing the gunshot injury scar. So let's see what we have got on ultrasound, or how the gunshot pellets look. So here I'm showing you a part of the thigh or buttock region, I think. So you can see this is the round structure which is embedded into the muscle area. So you can see this structure. This is the gunshot pellet, like that ball I have shown you. So that lead ball actually. So you can see it here, which is embedded quite deeper actually. So you need to remove it. It will be difficult. Okay, so this one is the gunshot pellet. You see, it's quite easy. Like you put the linear transducer, you can locate it. So fortunately, it's one here. If it was hundreds there, it would not be comfortable to do ultrasound of each and every one. Okay, so it's located around 4 millimeter deep to the skin, so not so deep actually. And it's around 2 millimeter thick. Okay, so the width of the ball is 2 millimeter. Okay, so this is the pellet. It was located, I think this is, I think this is the picture of the thigh region actually. Okay, so here is the scalp of the patient, and over the scalp you can see this is the skin, and I think I have seen that structure. This is the area of the pellet. You can see this irregular something located here. So this one is the pellets. Now, as I need more high frequency transducer, I don't have that. So it was not easy for me to show you that pellet here quite well like the other picture. So if I have more than 15 megahertz transducer, then I could actually show you a better picture. So this one is the pellet. Okay. So it's showing a round texture. So fortunately, the skull bone underlying it is not broken. Okay, so this one is the pellet. So it's also 2 millimeter. So another one, it is located at the parietal wall of the right abdomen. And you can see this is structure, this one. It is just attached to the skin actually. So you can see it's showing two echogenic lines here. So I was looking at these parts and now I can see this one is the pellet actually. So it's located most superiorly, I think. Okay, where is the pellet? Where is the pellet? Oh, this one. Here you can see this one is the pellet here. So this patient has got 2 or 3 pellets around the thigh actually. So it was disgusting. So this was a case of shotgun pellets in the soft tissues of different parts of the body. Okay, so let's jump into the case number 5. So it's a 55-year-old male patient who has a history of right upper abdominal pain and fever. Let's see what we have got on ultrasound. So here we can see the picture of the liver, spleen, and kidneys. You can see the liver is slightly enlarged depending on how you measure actually. If you look here, you can see this is the diaphragm and this is the upper pole of the kidney, and there is a gap or wide distance between the upper pole of the kidney and the diaphragm, which indicates the liver should get enlarged. Otherwise, why the kidney is getting pushed downward. So this liver should be enlarged. That's how we actually look at the liver and say that, oh, this should be the hepatomegaly, not measuring the liver first. So we look at the liver, we see the kidney is getting downwards. So definitely the liver should get enlarged. Otherwise, it should not happen. Anyway, so let's look at the liver now from different angle. And here you can see an heterogeneous area. This heterogeneous area is showing an irregular ill-defined wall. Patient is having a little fever and pain, obviously. And you can see some hazy collection inside. So definitely it should be an abscess. So this is a hepatic abscess. So it's a very notorious collection, I think. So let's magnify the image a little bit, and you can see here this heterogeneous collection with internal thick septations-like appearance. Oh, so this is a large lesion here. It extends way more than I thought actually. So you need to drain this abscess through pigtail catheter or anything. So we put the color Doppler. Unfortunately, I don't have the video of the color Doppler, but you can see it's showing prominent peripheral vascularity, but there is no vascularity within the collection, obviously. So this is a case of hepatic abscess. So let's see it from different angles. So now you can see this abscess. It is located quite nearby to the diaphragm. which is a common location for the amoebic abscess, but the patient has the feature of, I think, pyogenic pattern. So it's quite difficult to distinguish all the time, but this is a hepatic abscess, obviously. So here from different angle, we are searching for more abscess within the liver, because in pyogenic case, you may find multiple ones. So, but we can see only a single abscess here in this patient. Okay, so this is the hepatic abscess. And I'm not showing you this case only for this single abscess, obviously. So here's the picture. You can see this abscess here. Okay. So anyway, the patient came to me after 9 days again. So in this time, he went through a catheter drainage of this abscess, but still there was right upper abdominal pain. Pain reduced a little, and there was also the reduction of fever, but still the fever was present. Okay, let's see what we have got on ultrasound now. So the liver got slightly decreased in size now, and the kidney, right kidney became slightly echogenic. So this is actually the reactionary increased echogenicity, which is common in inflammatory states. Okay, we are not taking it seriously. We need to search for something else. So here's the abscess. You can see this abscess is now very small in size after a good amount of drainage. So it's getting healed. It's in a far better condition right now. But remember that whenever you see the hepatic abscess, you definitely, after drainage, you should definitely check carefully to see any more findings present there. So let's look another picture. So here you can see this was the abscess, which is now smaller in size, and the inflammatory condition surrounding it has got reduced. You see the only regular hepatic vessels are present here, so no much vascularity. These artifacts are coming due to the cardiac pulsation. So it's quite small in size right now, but it's ill-defined, and so the measurement should not be quite accurate. Now, let's look at the other parts of this patient. So when we are searching for the any other lesion, so we have found that at the most inferior part of the liver, you can see a hypoechoic, ill-defined heterogeneous lesion here. And you can see the infrahepatic or subhepatic region shows some thickening of the fat. Surrounding fat plane is thickened. So it took our attention. So let's jump into the real-time view. And here you can see this one is the abscess. Again, another abscess at the most inferior part of the liver. Unfortunately, you can see there is a collection that is going beyond the liver, and it's coming up to the subhepatic region. And you can see it's getting covered by a thick layer of omentum or mesentery, whatever you say. So this is now another hepatic abscess with a subhepatic inflammatory collection, or even you can say there is also a subhepatic abscess. So the situation is not quite good. So here you can see the glimpse of the lower end of the kidney, and you can see the most inferior part of the liver showing an abscess, along with an extension which is covered by the mesentery here. So we put the color Doppler, and you can see definitely there is a peripheral vascularity, as there is an acute inflammatory process going on here. So we are not happy. And here you can see we have put the power Doppler, and you can see the vascularity here. So this is a small lesion right now, and the patient is still having some abscess. So we took the sample. We have always say that took sample from whenever you see a abnormality and there is a vascularity. So we have took sample here, and you can see a moderate resistant flow from this part. So here's the collection, which is getting extended from the abscess to the outside of the liver, and it is surrounded by surrounding omentum and or mesentery. So this is a complicated case. So we just want to end as a hepatic abscess, but you have to describe it a long way to end the complete report. So before going to the sixth case, we just want to say that if you're new to our channel, please don't forget to subscribe our YouTube channel. And obviously, you're watching it from our Facebook page, so don't forget to just put a follow or like to our Facebook page so that we can grow a little more better. And if you're watching from any different groups, I have posted this video to many groups. So if you are watching from many groups or even my profile, so please try to make a comment on the Facebook live, not to the groups or to my profile, because I can only see the comments from the live video. So if you have any question about anything, just can put this question to the live. We'll try to catch you there. Okay, so let's jump into the case number 6. So this is a case of testis, I think. So this is a 31-year-old male patient. Okay, so but there was no palpable testis in the scrotum, which is quite unlikely because it's 31-year-old. Okay, let's see what we have got on ultrasound. So here you can see the transverse section of the scrotum. So we put the transducer transversely, obviously not this one. This is the linear transducer view. And we can see there is no testis within the hemiscrotum sac bilaterally. So this is the right one, this is the left one. There is nothing here. So this should be bilateral undescended testis, I think. Okay, so the scrotum is quite empty, nothing there. So the common location for an undescended testis should be the inguinal region. So we search for the testis in the inguinal region, but there was no testis within the inguinal regions. Okay, so this is the right inguinal region, which shows no testis here. So where's the testis then? So you can go for an MRI, but sometimes it's very difficult to locate actually. You can go for the testicular scans or something like that. So it's quite complicated. Patient came for the infertility actually at the age of 31 with no testis within the scrotum since birth. Okay, so that's a complicated situation going on here. So we try to search it on at the abdomen. So here on the right iliac fossa, you can see a hypoechoic oval-shaped structure adjacent to the intestinal loop, which should be the testis. Okay, so now with this similar setting, I can see the testis within the hemiscrotum, but this setting may not be good for the intra-abdominal searching. So I have changed the setting a little. Now you can see the bowels moving here and this hypoechoic lesion. Oh, you can see a calcification here. If you look carefully, yeah, there is a calcification here. So this is an intra-abdominal testis located at the right iliac fossa of this patient. So it's very difficult to exclude any macellation within this testis with this ultrasound probe. So it was very difficult. So here we have put the measurement. It's definitely small in size because it's located within the abdomen since gestational age. So it should be non-functioning or should be a very good fertile soil for developing the malignancy. Okay, so this is the testis. You should definitely comment on the calcification within this testis because it should take concern. So fortunately, alpha ferritoprotein was not raised. Okay, so on the left side, we found an inguinal hernia. There is an inguinal hernia neck here, which extends to the inguinal canal. So I don't want to go for the inguinal hernia right now, but there was an indirect reducible incomplete inguinal hernia on the left side. So it's going through the inguinal canal actually. But we want to look at the testis here. So now we want to jump into the abdomen again. And here you can see this testis. It is located quite slightly medially than the right one. And here you can see similar structure, oval shape, hypoechoic, located intra-abdominally. This is the bowel loop. This one is not the testis. So this one is the testis, hypoechoic, and it is located nearby to a vessel. This vessel should be the common iliac artery. So it's far above and medially located. So this one is the common iliac artery. I thought this one should be the external iliac artery, but this is far above the external iliac level. So it's the common iliac artery, which will get divided into external and internal slightly inferiorly. Okay, so let's change the setting, and you can see this hypoechoic oval shaped structure. And this is definitely the testis located intra-abdominally just beside the common iliac artery. So here again, you can see this testis in a magnified view, and I'm just trying to press it because if it is bowel loop, then by pressing over it, the bowel will move. So I can just exclude the bowel loop from the testis in this case. But this is the testis. It looks testis. Okay, so we put the color Doppler and you can see the vascularity. No, this is not the vascularity we see. These are actually the artifacts over the testis due to the surrounding movement of the bowel. So it's very difficult to see the vascularity in a small size testis like this. So we better should focus on other imaging modality. So we took the measurement. I think I have shown you the right testis measurement there. So both are small in size, almost 2.3 cc for each. Fortunately, there is no detectable mass present there. So this is a case of bilateral undescended testis. The right one is located intra-abdominally at the right iliac fossa, and the left one is located intra-abdominally just anterior to the left common iliac artery. And the left-sided reducible incomplete indirect inguinal hernia was also present. Okay, so this is a complicated case. So now jump into the case number 7. I'm checking the live section. So many of you have got connected from different parts of the world. Oh, okay, that's great. So let's start the case number 7. So here you can see there's a 62-year-old male patient came with hematuria. Okay, so there should be something abnormality going on the urinary system, I think. So here you can see the prevoidal volume of the liver, urinary bladder. So, okay, everything looks quite good except for the lateral side. You can see something is going on here. Okay, so now now on this image, you can see there is an irregular area at the lateral part. So this focal area, and the margin is not very good. This is irregular. So if this patient comes with the hematuria, you definitely should first give the concern about diagnosing a mass. So we just need to put some color Doppler. If we can see vascularity within this part, it should be the mass. So the transitional carcinoma is far common here at this location. So now we are checking it from different angle. Now you can see this lesion is quite irregular. There looks some calcifications here. The first thing that came into my mind is the impacted calculus at the view J, but view J is located here. So it's not the view J, but there should be some calcifications here also. Now we have put color Doppler, and you can see there is some vascularity, some artifacts from this calcification around here, possibly. So this lesion doesn't look quite good. So we just adjusted a little, and you can see there is a vascularity towards this mass lesion. So you may say that this is not the vascularity, this should be the artifact. So we can easily differentiate between artifact and regular vascularity using the pulse wave Doppler. So here you can see we have measured the lesion, which is around 2.1 centimeter, 2.1 by 1.1, I think. Okay, so we took the sample, and here you can see it is getting a moderate resistant flow of 0.69, and so this should be a case of transitional cell carcinoma on histopath. Okay, so we put the 3D ultrasound here. We love to check the urinary bladder mass with 3D. So now you can see this is the lesion here. So it's an irregular lesion. So just adjust a little and you can see it looks like a prosthetic enlargement like appearance, but it's from the lateral wall. So this is the mass within the urinary bladder. Now, whenever you see this type of mass, you definitely should check the urinary bladder after voiding. So after voiding, the urinary bladder will get contracted. So uh, this was the mass. Now it is getting contracted. So it will be a little bit thicker now. So let's jump into the post-voidal picture so you can understand. So now, if you look at this picture, it's a post-voidal image, okay? So you can see the urinary bladder, but here you can see an irregular area, slightly more thickened area at this part. So let's put the color Doppler, and on color Doppler, you can see an aggressive vascularity towards this area. So this whole part is the mass. My intention is to look at the extension of the mass. So as you can see prominent vascularity at the outer wall of the lesion, so there is a high possibility of involvement of serosa in this case. So you know the mass is getting developed from the transitional cell, which is located inside of the urinary bladder. But you can see prominent vascularity at the outer side, and you also can see some irregularity here. So there is definitely a possibility of serosal invasion, or even there might be invasion of outer part. So you should go for definitely an MRI or any other investigation tool that you want to exclude external invasion of this lesion. Okay, so that's why I was just searching it for on post-voidal residue pictures. So here you can see this lesion after voiding, and you can see the vascularity of the surrounding tissue, which is very unusual, and possibly there is a serosal extension. Okay, so this is simply a urinary bladder mass, possibly a malignant one. Now jump into the case number 8. This will be the musculoskeletal one. So it's a 56-year-old female patient who had a history of ankle pain. So she can't actually walk quite comfortably. And there is a visible swelling at the anteromedial aspect of the lower leg, or even ankle, whatever you say. So at this part, and this is the area of tibialis anterior tendon. So this is a very common site for development of inflammation. So we need to check it a little bit carefully. So let's see the picture. Okay, so here, oh, so here you can see this is the tibialis anterior tendon, which is quite thickened and very thick. And you can see the surrounding sheath is also thickened and edematous. So, okay, you can see some collection here also. So you can see the surrounding thickening of the tendinous sheath. So we just need a color Doppler now. So to end the diagnosis. So it's a long thickened tibialis anterior tendon. It's located anteromedially. So it's a very easy location and a very common site for developing inflammation. So let's look at the long section. And here you can see it is quite thickened. So very thick and hypoechoic tibialis anterior tendon. Okay, so this is the transverse section, and you can see it's thickened, and there is some collections here also. Okay, let's put some color Doppler. Oh, okay. So on color Doppler, you can see very high vascularity. So the tendinous sheath and surrounding area, the membranes, everything is getting very good supply here. So this should be a case of tibialis anterior tenosynovitis, which is a very common case in our practice. Okay, let's look at the tendon. Okay. So long section. So here you can see the surrounding vascularity is very high, and the tibialis anterior will get a good amount of supply because nearby vessel is the anteriotibial artery. It is also can get supply from the posterior tibial artery, which is also located nearby. So these areas are very notorious to supply the tendon in inflammatory case. So here on transverse section, you can see this lesion, and in long section, you can see this is a tendon which is thickened, and also surrounding inflammatory or edematous change of the subcutaneous layer is also seen. So here is another picture, and you can see this is the high vascular appearance of the tendon due to inflammatory process. And this one is the transverse section. Here you also can see this high vascularity and also hypoechoic thickening and edematous appearance of the tendon with surrounding area. So this is a case of left tibialis anterior tenosynovitis. Okay, so what is the treatment? What you want to do for this patient? Tell me in the comment below, because I'm not good in treatment. So now case number 9. So what about a pregnant case? So this is a 22-year-old female patient who came with amenorrhea for 6+ months. Let's see what we have got on ultrasound. Fortunately, it won't be a good case. Okay, so let's jump into the measurements. It looks quite like a 25 to 26 year, 6 weeks sized pregnancy. So all the measurements looks quite normal, and hopefully there is no growth restriction or something like that. So it just matches with the menstrual history. So fortunately, we are not thinking something bad. So this patient was sent to me for a fetal echocardiography. Let's see what we have got on ultrasound. So before going to that part, let's see some 3D image of this patient. So this machine is not very good for 3D, but it's good for practice. So these were the 3D images of the fetal face. So you can see the face looks quite good. Okay, so this is a slide video, but not very good. So taken from the still picture. Okay, so let's jump into the fetal heart. So this is the fetal heart here. You can see the transverse section of the fetal heart, not an optimized image, just decrease the width of the sector width, and you can see only heart here, and it doesn't look quite normal. So on first impression, you have three things that you can describe here. Number one, this is the spine, and you can see this is the left side of the fetus. Adjacent to the spine, the chamber lies is the left atrium. So this one is the left atrium, this is the left ventricle, this is the right ventricle, and this larger one is the right atrium. So my first impression is that the heart is covering almost all part of the chest. So this is a cardiomegaly, definitely, number one. Number two, you can see the right atrial enlargement. Number three, you can see where is the cardiac apex. So the apex should lie at this part, but the apex is deviated more towards the left because of right atrial enlargement. So we have already concluded the diagnosis, I know. So let's jump into another picture. So here you can see this image little adjusted, and there was no VSD or something like that, but you can see the right atrium is much enlarged. Now we want to look for the valves here because it's possibly having some valve related abnormality. So let's magnify the image. Now let's look at the tricuspid valve. So this is the spine, so this is the mitral valve, and this is the tricuspid valve, and you can see the tricuspid valves are not closing. So they're coming to each other but not getting closed. Number one. Number two, if you look here, you can see, let me annotate a little. So this is the level of the mitral valve, but the tricuspid valve lies slightly anteriorly. It's not a good picture to describe. I will show you some from some still picture. So the tricuspid valve is located slightly towards the apex. Uh, this is the right atrium. So definitely, if you look here, it should be located here actually, because that in a normal right atrium, if you compare the normal right atrial size, it should locate there, but it is displaced towards the apex, and the right ventricle is now very small in size. So we call it the atrialization of the right ventricle. So right ventricle looks like an atrium. So we have got many findings like the enlarged heart or cardiomegaly. We have found apical displacement of the tricuspid valve and it is not getting close. So on color Doppler, you should expect some tricuspid regurgitation. The right heart is also enlarged, but especially the right atrium is enlarged, not the right ventricle. And the right ventricle got atrialization. So these features concluded as a case of Epstein anomaly. Whenever you see a case of right atrial enlargement and displacement of the apex towards the left, you first should think about the Epstein anomaly. So let's jump into this part. Here you can see the tricuspid valve is displaced towards the apex, and you can see the right atrium is quite enlarged. The left right ventricle is getting small in size and getting atrialization. So we have checked some measurements. Don't expect much better measurement because my machine can't trace the image. So hey, machine manufacturers, you should put some options to trace the images. So I rather now prefer to measure this type of transverse diameter of the chest and diameter of the heart like thing. But this is not actually good for this image, so I won't go for that. But if you look at the chest, you can easily understand that this heart is quite enlarged. So you don't really rely on this measurement. So rather, I would love to go for the axis measurement here. So I have drawn a line from the spine to the sternum, and I have drawn a line through the interventricular septum, which made a 112 degree of axis at this part. So the normal axis should be 45 degree plus minus 20. So it's far beyond the normal limit. So this is definitely a deviated heart towards the left. Okay. So let's put some color Doppler, and on color Doppler, primarily you can see there is a very high flow jet coming backward. So just freeze the image. You can see this is the inflow, and at the time of inflow, you still can see this regurgitation. So just at the end of the flow, you can see a very high regurgitation from the tricuspid valve here, which is the feature definitely of this tricuspid valve regurgitation. So this is typical tricuspid valve regurgitation, which is a common association in Epstein anomaly. Okay, so you want to confirm it as a tricuspid valve regurgitation, what you need to do is to put the pulse wave Doppler. So here we have put the pulse wave Doppler. So you can see I have put the scale of more than 60, because if I can see more than 60 centimeter per second of regurgitation, I would love to call it a tricuspid regurgitation. And here you can see the reflux is far more than 120 centimeter per second. So definitely there is a tricuspid valve regurgitation. So this is a severe tear here. Okay, so don't forget to look for any other abnormality. Patient was sent to me for fetal echocardiogram, but there are some features also outside the heart. So I tried to locate them, and here you can see this is the left kidney of the fetus, and this left kidney is showing some fluid inside. So it might be normal or it might be abnormal. So to say that, we need to measure the anteroposterior renal pelvis diameter. So the anteroposterior renal pelvis diameter at less than 28 weeks of gestation, it should be up to or less than 4 millimeter. Now it was 5 millimeter around, so slightly increased. So we'll call it the urinary tract dilatation, which is of category A1, which is the low risk variety. Okay, so this was a female fetus. I don't do gender determination in my chamber, but this was a female fetus for congenital anomaly purpose. I just want to disclose to you because you don't know this patient and the patient doesn't have any idea about what gender was. Okay, so this was a case of Epstein anomaly. We found severe tricuspid regurgitation also, and there was a left-sided urinary tract dilatation, which is classified as UTD A1, low risk variety. If it was more than 7 millimeter at this age, we'd call it type A23, which is high risk variety. Okay, so in case of Epstein anomaly, you will see the apical displacement of the tricuspid valve, and there will be atrialization of the right ventricle, and also tricuspid valve regurgitation is a very common feature in this type of cases. So you'll see the right atrial enlargement type of cardiomegaly. So before starting the last case, I can see today we don't have much comment here. So it's just showing me the, okay, so there are some comments. Thank you, thank you. Very low. Okay, anyway, let's jump into the case number 10. So these are, I think, boring cases today. Anyway, so let's just start with the case number 10. This is, oh, I think I have made some mistake here. So I didn't actually, no, this is correct. Okay. So this patient came to me. This is a 19-year-old male patient who came to me with a some history of hematuria. Sorry for that. And there was a history of umbilical discharge. Okay, so let me just edit a little. Umbilical discharge. Sorry for that, because I didn't have a chance to adjust. So there was an umbilical discharge here also. This patient also had hematuria. So let's see what we have got on ultrasound. So I was thinking about some urinary tract inflammation or something like that. So possibly it's from that part. There was no significant finding. But when we looked at the umbilical region, so we can see, my focus is towards the umbilicus. You can see some sinus tract here. These are the, what are these? These are some tubular structures. These are not abnormal. But if you look here, there is something abnormality going on here. There is a sinus tract which is forming some abscess cavity-like thing. I think so. I need to look it very carefully. So let's jump into the transverse section. So on transverse section, you can see, these two are not abnormal. So let me freeze a little. So let's jump into here, and you can see below the umbilicus, there is a sinus tract here. You can see some hazy collection here. So these are definitely the inflammatory collection or abscess. So it is located up to this part. Now, if you look here, you can see two tubular structures going there. You see these tubular structures? What are these? So these are the medial umbilical ligament. Actually, these are the remnant of the umbilical artery, I think. So, so this is not our concern. It came to its way, but you can see there is a collection below the umbilicus. So let's jump into another view. So now you can see there is surrounding inflammatory process going on. You can see a collection at the central part, just through the umbilicus. So we tried to find any extension to the urinary bladder, as the patient has a complaint of hematuria. So we just wanted to search for the continuation. But on previous image, you saw that we tried to search for that, but we can't see anything when we jump into inferiorly to the liver, to the urinary bladder. So it has no communication with the urinary bladder, hopefully. But you can see an abscess at the central part forming the sinus tract through the umbilicus. So let's look at the long section again. So now you can see this is the umbilicus, and there is a sinus tract which is showing some abscess cavities, and it is coming downwards up to the muscular layer here, above the muscular layer, but there is no intraperitoneal communication at this part. And you can see it finished at that part, but you can see the medial umbilical ligament at these areas. So what should it be? So this is called umbilical urachal sinus. Okay. So here you can see this sinus tract here. So this is the sinus tract, which is also containing some pus-like fluid. So now you can see it's around 4 and 1 centimeter in length. So I measured it from tracing, and you can see this is the abscess cavities which are supplying the pus outside. So this is the abscess. So you can see the vascularity. So it's forming a sinus tract. So it's a complicated case. So let's describe it a little. So the umbilicus shows a thick-walled, well-defined sinus tract. We have put the location, size of this lesion, with internal heterogeneous collection extending from the umbilicus to the tip of the rectus. musculature in midline with no communication to the urinary bladder. This is important because if it gets connected to urinary bladder, the situation will get changed. And the surrounding increased vascularity with edema was also seen on color Doppler, so which suggests it to be an inflamed or infected umbilical urethral sinus. So this is the situation going on here. Okay, so it's a little bit unusual case. You usually get the umbilical granuloma or something, but whenever you see the umbilicus region abnormality, you should definitely try to trace it up to the urinary bladder. So to see or to exclude any communication with the bladder. Okay, so you don't have to search all over the abdomen, just search at the midline and try to trace the median umbilical ligament and try to see the communication with the urinary bladder. Okay. So thank you for joining me for this long session. And we have another session, but it will be a little bit delayed because we have a program next week. So we'll take our next session on 13th December. So we'll make a gap on next week. So it will be also free and Facebook Live like this one. So if you are connected to me from the YouTube, so don't forget to check our YouTube channel also, because we'll just post this one 1 or 2 days later to our YouTube channel. So you can also get this one from the YouTube. So anyway, thank you. So we have a YouTube channel named Imaging Study. We have already mentioned it twice, so sorry for that. We have got 59K plus subscribers, and thank you all for being with us for a long time. So our channel is running, I think it's 5th year right now. So this amount is far beyond our expectation. Unfortunately, we have got 464 videos. Not all the videos are useful, but you may find some useful for you. We have a website named imagingstudy.com. You can also visit that, though we need to nourish this website more. Okay, so thank you for joining me. If you have any question, you just can put this question. And don't forget to follow our Facebook page also, because we will continue developing our Facebook page so that many of you can get a resource material from that part. You also can get announcements from this Facebook page, and also we'll post our videos here also. So don't forget to visit there. So if you have any question, you can ask about any case you want. Okay, there's no question. Let me just check a little, then we'll just close it. Okay. Just let me check a little, then I will close it. Okay, here I can see 38. Okay, thank you. Yeah, it's okay. We don't run any ultrasound course actually, but we try to share our cases with you people. And there is a question about the direct and indirect inguinal hernia. It's a very easy thing. Like if you see the hernia is coming through the inguinal canal along the spermatic cord, it should be the indirect inguinal hernia. This is the easy one. But if you want to make it a little bit complicated, you can put the transducer transversely at the hernial neck region and try to locate the vessel, which is called the inferior epigastric vessels. So if it is located medial to the inferior epigastric vessels, we remember it as MD, doctor in medicine, MD. So if it is located medial to the hernia, sorry, If the hernia is located medial to the inferior epigastric vessel, then we call it the direct inguinal hernia. And if it is located lateral to the inferior epigastric vessels, we call it indirect. So you can check it on transverse sections. And if you can see that it is coming through the deep inguinal ring to the superficial inguinal ring through the inguinal canal, you will definitely say it as an indirect hernia. So indirect hernia traces its path through the inguinal canal. Yeah, you can go for the sinogram. That's an excellent investigation, I think. Some want to go for the hernia MRI also. Well, we are taking our online paid sessions for only local peoples actually, because we arrange it in local language, not for the English. It's very difficult for me. So that's why we can't invite foreigners for those sessions. Actually, you can't understand anything because we will talk in our own language. And again, there is an issue with the payment because we can take payment from you. It's very easy. The rate is not very high. We know that. But the main problem is that if we cancel any session, we can't refund you because refund process is very difficult for us, for the foreigners. So if we can't refund you, we can take money from you. So that's why we can't, we are trying, but we can't arrange any program for the foreigners. So that's why we are arranging free sessions only for the foreigners. You know, our YouTube channel has got 92% of subscribers from, not from my country. So that's why we need to arrange something for you. Actually, this is our responsibility. Okay, the English is okay when we are going through some case demonstration, but when we want to go for the detail, it will be very difficult for me. Okay, so anyway, we'll try to arrange. Okay, so if we can manage the refund procedure, or if we can collaborate with any other society, then we can arrange. We're trying with that actually. Someday we will try to make it possible. Okay. So anyway, thank you very much for joining me for this long session. We're very grateful for you as you have given us a very valuable time of from your day-to-day life. Together we can actually improve the ultrasound throughout the world, not for my country, not for my village, not for my subcontinent. So we want to improve it throughout the world. That's how we can actually do some work for the humanity. So thank you for joining me. Hopefully we will meet again in another session. And don't forget, we'll have a session on 13 December, 2:30 p.m. GMT. So calculate it from your country time. And hope to see you there. Till then, thank you. Thank you.